Okay, sorry about that. That was my mother. Family thing going on. Let me get the test back up here. Hold on. Okay. Um, Sorry. All right, here we are. Question 9. A patient presents with palpitations. You check lab work and find that her potassium is greater than 6. You see that your patient is taking Lasix and spironolactone, which are both diuretics for the treatment of her heart failure. You also recently added an ACE inhibitor for her low ejection fraction. Which of the following statements best explains the high potassium while on two diuretics? Okay, so the question is asking patients on two diuretics, and usually with diuretics we see, um, low potassium, which Lasix is most notorious for. We also know that spironolactone or aldactone is potassium sparing. And the correct answer here is spironolactone is a potassium sparing diuretic, and ACE inhibitors are also potassium sparing. So we've got two medications that are hanging on the potassium, with one not decreasing it. Now, this is not always going to be the case. This is not saying don't give aldactone and ACE inhibitors with Lasix, because it always has its time and place. But for this particular situation, uh, that is the explanation. Now, this question doesn't say what are you going to do. It just says what is the explanation. So the explanation is one of the diuretics and ACE inhibitor both are potassium sparing. All right. Question 10. Patient with atrial fibrillation should probably not be prescribed hydralazine. Why? Hydralazine is useful for the treatment of hypertension but can cause rebound tachycardia. And rate control is the most important factor with treating atrial fibrillation. So I don't think anybody missed that one. Number 11, which of the following vasodilator combinations can be useful in the treatment of congestive heart failure? This is one I talked about on the lecture. I think it's in the book too. Here we have nitroglycerin and Imdur. That's a negative. Those are both nitrates. Imdur and Coreg, nope. A patient can be on both of those, but they don't have the combined effect. Hydralazine and nitroglycerin, close but no cigar. Nitroglycerin is a nitrate, but it's not long acting. So the real answer is hydralazine and Imdur. Those both have a magical effect on the treatment of heart failure by reducing workload. Um, when I say magical, I'm really not that far off because what you'll find as you read more and more scholarly literature, what you should do is pick out a couple of different medications and go to the American Journal of Medicine and or the Journal of American Medicine Association and read some of the first publications on some medications, and it will, like Coreg, for example, in the original publication, it says, we're not sure how it does what it does, but the research shows that it does. There are many medications that we don't really know how they work. We just know they do. Okay, number 12, an important side effect to warn your patients about when prescribing ACE inhibitors is angioedema. True or false? True. It's a side effect. Make your lips swell, close your airways. Not a cool thing. You're treating a patient for asthma. Oh, this is question 13. You're treating a patient for asthma. She returns for a follow-up appointment and reports that she has been using her short-acting inhaled beta agonist more often. This is asthma, along with a long-acting beta agonist. So you're already going to prescribe that. Which of the following would best benefit this patient? So Pulmicort, that's an inhaled steroid. That's for much later on. Albuterol, ipratropium, that's Duoneb, really more for the treatment of COPD. The patient is with asthma. We're talking about rescue situations. Prednisone, not right now. The whole steroid thing is for much later when there's absolutely nothing else to do. Steroids are definitely indicated for acute exacerbations. For short-term use, absolutely. If you want to give your patient a Medrol dose pack. But the answer is what we're talking about is for long-term management is Singulair. It's a leukotriene modifier, very helpful for asthma. Okay, question 14. Patient presents to your office in late fall with a persistent cough and wheezing. You know this patient well, and she has a history of COPD. Her condition does not warrant hospitalization. Which of the following treatments would be most appropriate for her symptoms during this office visit? This says IV steroids and Symbicort. No. Mucinex and Zyrtec. Nah. This says intramuscular steroids and a Duoneb updraft, which is the correct answer. And the other one's Nicoderm and a Duoneb updraft. So some of these questions or some of these answers are ridiculous, and hopefully you figured that out. But this question is making you think, what can I do at the office? It's not hospital worthy, but what can I do? So there are many options, but for these questions, IM steroids and a Duoneb draft. Of course, oral steroids, prednisone pack, Medrol dose pack, those are acceptable as well. So number 15, theophylline can potentially cause fatal, it says aortic dissection, diarrhea, stroke, and cardiac arrhythmias. And of course, it's cardiac arrhythmias, and that's discussed in the book and in my lecture, that these are really some of the main side effects they have to watch for. But on occasion, people are prescribed this because it's either that or die of COPD, so we take a risk. All right, number 16, intranasal steroids are helpful for allergic rhinitis. They can, however, cause rebound congestion. This says rebound tachycardia, rebound hypertension, and adrenal crisis. So rebound congestion is obviously the main issues, because your nose gets used to the steroids. It has withdrawal symptoms. Okay, number 17, I've taken this quiz by my own efforts. If you didn't answer true on that one, we won't talk about it right now. The use of, number 18, the use of anticholinergics for the treatment of COPD works by relaxation of skeletal musculature. That is false, because it does work on muscle relaxation, but it's the smooth muscles that wrap around the bronchus and the bronchioles, the airways. So it's a smooth muscle sort of thing, not a skeletal muscle. Which lab test would you include in a workup for your patient on whom you're about to start a statin drug for the treatment of hyperlipidemia? Okay. So thyroid function, no. Hemoglobin A1C, no. So there's an answer on here that's tricky, and I intended for it to be that way. It says lipid panel, but the real answer is liver function panel. Okay, why is lipid panel incorrect? I don't think anybody's asked me about this, so I don't think anybody missed it. But, well, you should already know that they have hyperlipidemia before you prescribe a statin. So we know that statins can cause hepatic dysfunction. So you want to check a baseline liver function panel. The 20, and I keep looking over here, it's a list of questions that people have asked me about. A patient presents to your clinic with complaints of myalgias for the past week. She is also not urinating as much as usual. She takes Zocor or Simvastatin for high cholesterol. Which of the following findings would you expect to find on her laboratory data? So troponin of 13.6, probably not. That's more consistent with a heart attack at that high. You will see elevated troponins with what I'm talking about on occasion, but not that high. Calcium 7.9, that's got nothing to do with it. Potassium 5.2 also has nothing to do with it, and that's actually not high. And of course, it says creatinine kinase greater than 15,000. And that's what we expect, because what we're talking about here is a statin-induced myopathy, and this does happen, I've seen it a few times. Statin drug itself causes myolysis, which is a breakdown of muscle tissue, and of course all those proteins clog up, and